Good evening, everyone. Welcome to another Medical Mondays with Dr. O. I am Toyin Okpesomi, a family practitioner, HIV specialist, and I treat addictions in Maryland. I'm in private practice, stretched across the state, having fun, enjoying my patients. But my passion is really in prevention, in educating each other, growing together, and just learning how we can be healthier and better in our communities. So, as a result, we come every Monday night to come share knowledge and grow together. Tonight, we have our very own Dr. Oluyemisi Famuyiwa, who is a guru, expert in fertility. She has been instrumental in many of my personal patients becoming parents today. And it's a privilege to introduce her on our forum tonight. Dr. Famuyiwa, take it and run with it. Welcome.
Thank you very much. It's fun coming to this wonderful forum. And I want to thank Dr. Okpesomi for arranging this. It's not easy to organize such a big webinar. And I want to thank everybody in advance for spending some time to be with us tonight. I know you could be eating dinner. What I'm going to do tonight is just basically go over some of the workup that we do for an infertile couple. And I have to apologize in advance, but I don't know how to oversimplify. So if it looks like I'm getting a little too technical, please stop me, but I'm sorry about that in advance.
Don't worry, I'll help.
So when we talk about a fertility workup, it basically revolves around the uterus, right? The ovary, and of course you need sperm. That's really just boiled down to the very basic nitty-gritty. And we can talk about how some of this are very important. So I'm going to start with workup of the uterus. All right. In order to have a baby, I always joke that you need 3 basic ingredients. You need egg, you need sperm, and you need a place to put them, the uterus. So the first thing we need to talk about is the uterus. Does it have anything that's impeding pregnancy? Is it distorted in any way? Is the fallopian tube open? Because if the tube is blocked, I'm gonna go this again, then you cannot get a pregnancy. So one of the workups we do is you need a sonogram to get an overall idea of what the uterus looks like. So you need a sonogram to make sure you don't have any fibroids, what's going on in the pelvic cavity. And you need a study basically called a hysterosalpingogram, where you have dye injected into the uterus, and you want to see if the dye comes out of the tubes to see if the tubes are blocked or open, okay? Then the other workup, this just shows a detailed anatomy of the uterus. What you don't see here is shows sperm from an ejaculate going through the cervical mucus, traveling up the uterus into the fallopian tube. It is in the tube that the sperm will encounter an egg that is ovulated out of the ovary. It goes into the fallopian tube, and the sperm that is strong enough to swim up this tube encounters the egg and it fertilizes it. And the fertilized egg becomes an embryo, and the fallopian tube gradually moves the embryo all the way down to the cavity, okay? So you need some continuity of the conduit. Otherwise, you will not get fertilization, you will not get a pregnancy. So you might hear your doctor say you need to go get a hysterosalpingogram or an HSG. The HSG is simply a dye study where you have dye inserted through the cervix, and while they're doing it, they take X-ray pictures. So you can get direct movement of the dye coming up the tube. Now, obviously, if the dye can't go past, then you know the tube is blocked. It also lets you know actually what the shape of the cavity looks like. So the dye will feel the shape of the cavity, and this almost like a V-shaped pattern here. Anything that does not resemble the shape is abnormal. It could be a fibroid pushing into the cavity. It could be a polyp occupying the cavity. It could be the cavity is septate, is divided in two. So it gives you a lot of information. And you can now say, okay, something is going on. Another thing that we now work up nowadays is to see, is this lining, see this pink area? That's where the embryo has to implant. We can now test to see if this lining is actually receptive of an embryo. Because if the lining is not receptive, you could put the best embryo all you want, as many as you want, the uterus will not get pregnant. But that is not part of a basic workup. That comes if you've had failed attempts at pregnancy, is when you can test that. But the very basic one is do an ultrasound, see what the shape of the uterus is, any fibroids in there, get an HSG done, what is inside the cavity, does the dye come out the tube, is the tube open? All right, now the sperm. See how small the sperm is in relation to the egg? You want to obtain a basic semen analysis. That will tell you about, number one, how much volume is in the ejaculate. Number two, the pH of the sperm, it should be slightly basic. Number three, the shape of the head of the sperm. See how it looks almost like a little bullet here? Well, there are some sperm, they may have abnormal shaped heads, bent heads, double heads. You want to look at the tail. Is the sperm able to move and move in a progressive, rapid fashion? Because if, let me go back to this slide a second. If the sperm cannot move, there's no way it's going to swim past this mucus and swim up the uterus and get to the tube. The tube has what we call cilia surrounding the lining that beat almost like a moving carpet to move the embryo into the cavity. But for you to get that, the sperm has to make it up there first. So it can't move, it can't get in. And then so we talked about the shape, the morphology, the concentration. There is a little sac at the tip of the sperm that you cannot see in this picture called the acrosome that contains a little chemical that can dissolve a hole in the egg to allow it to get in. However, one sperm doesn't have enough chemical to do the job. You need several working together. That's why some people say, well, why do I need 50 million sperm when I have one? That's because you don't have enough to drill a hole in, right? So you need that concentration in order to release enough chemicals. Once you have a sperm get in to the egg, there is a reaction at the surface of the egg called the cortical reaction that hardens the rest of the surface of the egg and prevents you from getting like a dozen sperm getting in at once, which obviously will give you a genetic problem. Another thing that we now know, again, not really part of the basic workup, is some sperm can have damaged or fragmented DNA. And you tend to see a lot more of this as men get older. So yes, your sperm does get old. So the DNA of the sperm is also important. If it has a lot of oxidative stress, if it has fragmented DNA. And now there is a way of preparing the sperm where you can try to sort out the sperm cells that have damaged DNA. Again, not part of the basic, but just sharing information with you. And I've been using that a lot with my patients. And it increases your chances of getting a genetically normal embryo if you have a normal sperm. Now, the ovary. So the other part of the evaluation is to look at all the factors that affect the ovary. And let me see. Okay, I'll start with this slide. Women are born with a fixed number of eggs located in follicles. Those follicles are constantly growing to about 8 to 9 millimeters. And if they don't see any signal from the brain in the form of follicle stimulating hormone, they die off, right? So you have that constant wave of activity ongoing. When it gets to a certain size, it gets to what we call a gonadotropin dependent size. That is when it can actually be picked up by the FSH, somewhere between here and here. And what I like to tell my patients is FSH doesn't just signal pick one follicle. You will pick a basket of eggs, out of which one becomes the dominant follicle, and the rest of the basket dies off. And that one follicle becomes the one that ovulates, as you see in this picture. And when it ovulates, the egg comes out. The rest of the follicle becomes this yellowish structure called the corpus luteum. And this corpus luteum will die off in 2 weeks and be called the corpus albicans, okay? This phase of growth, the luteal phase, is always stable. It's 14 days. This follicular phase can be variable. Now, if you relate it to the uterine cycle, somewhere around here, maybe when your period starts and you're having a period flow, you have small antral follicles. And then as the follicle starts to grow, you see this pink area that they highlight here is an increase or proliferation of the endometrial layer by estradiol being secreted by the granulosa cells from the follicle, sort of trying to get the baby, the uterus ready for preparing a bed of implantation, if you will. And then when you have the corpus luteum, it will maintain this lining in case there's an embryo that implants, and it will maintain it till the placenta takes over. If there's no baby, nothing to maintain the lining, and there's no more progesterone being secreted by the corpus luteum because it dies off, you shed, then you start all over again. One of the things I always tell my patients is, please write down when you start your menstrual cycle, full flow. Because a lot of women come to me and say, well, you know, my cycle is kind of, okay, hang on a second. When was your last menstrual cycle? Oh, I think no, don't think, write it down. And when I say, how many days between your cycles, I mean a start of the menstrual cycle to the next start. It may typically be 28 days, it may not. So when we refer to the interval, we're talking about start to start, not finish to start, okay? And of course, we'll ask you how many days you bleed for. Now, the reason I sort of summarize what's going on in the ovary, because the ovary, it responds to signal from the brain. It can also be influenced by extra signals that were not meant for it. For instance, if you have a thyroid problem, if you have elevated insulin levels, if you have either from diabetes or from polycystic ovary syndrome, all those things can affect the ovarian cycle. If you have elevated androgens, it could block off the progression of these follicles. So then you pile up the follicles behind your block, say about here. And when you look at the ultrasound, you'll see all these multiple small follicles. They're perfectly healthy. They're just being blocked. And you see those women they don't regularly menstruate, but they're not also ovulating on a regular fashion. They may ovulate sporadically, but it's not regular. And it's hard for them to time and predict. What really controls the ovary? Well, let's talk about the signal that the ovary needs. It's coming from the pituitary gland, and I guess this slide should come after the next one, really. Pituitary gland is located, if you were to will, point a line straight between your eyes and another one straight under your head. Where they intersect is where your pituitary gland is. It's made of the anterior pituitary and the posterior pituitary. And the anterior pituitary secretes FSH, follicle stimulating hormone. It also secretes LH, which is the signal that causes the egg to come out when you ovulate. That's what you test for when you do the ovulation kit. It gets its signal from the hypothalamus. You see these nerve fibers coming from higher up in the brain? They send down GnRH, or gonadotropin releasing hormone, down to the pituitary, which releases its hormones. And again, I was trying to show you the location of the pituitary gland. Draw a line roughly straight back here and straight down. And you see the pituitary gland is located in what is called the sella torsica. All right. And it gets a signal from this area of the brain, which is called the hypothalamus. Now, we do check the hormones that come from the pituitary going to the ovary. And those hormones are delivered in a cyclic and pulsatile fashion. And it really matters what time of the month that you measure them. So typically you might ask us, we might ask you to get blood work done on the second or third day of your menstrual cycle. Is because these hormone levels will change throughout your menstrual cycle. And the information we gather is important. Another thing that we ask you to do is to also measure what is called anti-Müllerian hormone. Anti-Müllerian hormone is produced by those small follicles I showed you in the ovary. So when you start to run out of eggs, one of the first things that starts to go away is your anti-Müllerian hormone, or AMH. So we also measure that. And the AMH does not depend on what time of the menstrual cycle you're in. It's independent of the cycle. So it doesn't matter. You can check it anytime. But for simplicity's sake, I usually add it to the blood work that I get. And I also add a thyroid, a TSH, thyroid screen, because that can affect your ovaries as well. So again, this just talks about how the brain, remember that area of the brain that says the hypothalamus, sends signals down to the pituitary cells, which in response to this pulsatile manner will now secrete hormones that go through the bloodstream and will make it its way all the way down to the ovary. And that's where the signal is read, interpreted, passed on. So when we are doing a basic workup, this is a little bit of what we have in mind, what we are processing as we are investigating. All right. So I always tell patients, when I see a patient and I'm talking to you, in my mind, I'm already sort of going through this step by step, and in a sequential fashion, asking you to collect certain information. And then when you gather the initial basic information, we now have another big sit down talk where we now put all this information together and say, okay, what's going on or not going on? And what can we do for the patient going forward? We formulate an individual plan. That is a very, very brief summary of what we do when we run our investigation. So I'm going to get out of my slideshow, if I can, and then I will open up for questions.
Thank you so very much, man. That's very, very important for us to know, because like we were discussing before we started on the forum tonight, fertility has become a very important issue. There are so many people battling with the need to, have children. And for some reason or the other are having difficulty. So thank you so much for taking us into the inside of what you do, how you figure out what is going on. So I want to ask, do you know why today we have so much infertility? Because I don't remember it being so bad. Is it a blockage of the egg? Is it the sexually transmitted diseases that have blocked the tube that you showed us? Or is it something else going on? It's definitely not genetics.
Well, I think if you look at worldwide epidemiological data, they will show that fecundity, the ability to get pregnant, has been slowly going down over the years. And we also have increased incidence of male fertility over the years. Is it environmental? Is it genetic? Is it what we're exposed to? Probably a combination. Are you living close to where there are environmental contaminants? What kind of diet do you have? What do you expose yourself to? So one of the things that I always discuss with my patients is their lifestyle. I go into detail with what are you exposed to? What medications are you on? What's around you? What kind of work do you do? Trying to figure out, is there anything that we can do to try to improve and restore fertility? Now, when you make lifestyle changes, it takes almost 6 weeks or so for it to have a positive effect, right, on your eggs, and probably even longer on the sperm. So lifestyle, diet matters. When patients come to me, one of the things I do give them is what I call my fertility action plan. And it includes lifestyle modification suggestions. It includes a diet where I list all the sorts of food that have a beneficiary effect on fertility. And I tell them, you don't have to eat everything on there, but it gives you an idea so you can prepare something similar to eat.
Thank you so much. I have another question. The male sperm. When we talk about fertility, especially in our community, we think women. It's always the woman's fault. The woman is the reason why baby is not happening. In our community, especially African communities, the mother-in-laws will go after the woman. But I've seen case after case in recent times where the man is the problem. You know that. We've shared some patients that, the man is the problem. In fact, some men have Klinefelter syndrome.
Correct.
Can you address this, the male factor and, the Klinefelter?
So Klinefelter is a chromosomal anomaly where they have 3 sets of DNA. And what happens is with that extra chromosome, it also affects their sense of smell, but it affects the ability of the testes to produce sperm. So a lot of these gentlemen will present with either no sperm at all or very few. Some of them will. Some of them may have what we call a microdeletion on the Y chromosome. And depending on the level of the deletion, they may even have a little sperm left or none at all. So when somebody presents with, severely low concentration of sperm or none at all, we always do a DNA analysis on them to rule out any genetic problems. And also we do hormonal testing to see, is it because they have what we call a HPO, hypothalamic pituitary axis failure, where they're not getting the signal from the brain, like I showed you, to their pituitary gland, and that can affect the signal going to the testes and their ability to produce sperm. Another thing to realize is some people have even proposed that a semen analysis may also serve like almost like a vital sign for a man, because it could just be a warning of something else going on. I've had patients that we've diagnosed testicular cancer in them, and the first warning was they had an abnormal semen analysis. And when we worked them up further, we found they had testicular cancer.
Okay.
Some men may have uncontrolled diabetes, and that can affect their semen parameters as well. If they have systemic illness, kidney failure, high blood pressure, it may also present with an initial abnormal semen analysis. So when I see an abnormal semen analysis, I usually like to have my gentlemen undergo a workup, preferably by a fertility urologist, to make sure that they don't have other significant diseases that could shorten their lifespan, for sure. So there are multiple ways that you can arrive at an abnormal semen analysis. So sometimes it's a warning, a signal that you need to look further.
Thank you so much. I'll come back to me, but I want to take, just 1 second to, acknowledge the fact that Honorable Gustav is not here tonight. I'm sure you miss him. You can tell nothing was posted in the chat box. When I remember the chat box and I went there, I'm like, oops, he would have posted and reminded you to, post your questions on the chat box or raise your hands. And so we miss him tonight. It's work. He got caught up at work, and he sends his greetings to everyone on the forum. So I'm going to call on my darling sister, Marian Ogutimehin, my classmate from high school in Nigeria 50 some years ago. And she logged in from Nigeria today. Marian, go ahead.
Awesome.
Yeah, good evening, everyone. Good evening, Dr. Famuyiwa.
Good evening.
Thank you so much. Yeah, I actually want to ask a question concerning a young couple. So they got married, that was last year, and she had miscarriages about 3 times now. Going for medical checkup, they realized that she is having high prolactin.
Ah.
So yeah, she was placed on one medication, I've forgotten the name. Instead of going down, it was coming up.
Yeah.
So presently, she's just placed on Dostinex also.
Yes.
Uh-huh.
Yes.
Yeah, so in fact, she just started that one today. So I just want to ask a question.
Yes.
What actually is the effect of that prolactin in connection to the pregnancy or fertility? And will that medication alone work? Or are there some other things that she's supposed to add to it?
Yes, let me, can I show you my slide again? Let's show you what's going on here with prolactin. So I'm going to let's share my screen. Pardon me, it takes me a while. I'm not this technical stuff. So I think I had showed you a slide at the beginning that shows the pituitary gland, right? And I told you that it derives a signal, its command, from the hypothalamus. This is the pituitary gland over here. Now, you can get a tumor of the pituitary gland. Most of the time, they're benign. And most people don't know because they don't secrete that much. But if your tumor decides to go haywire, the cells in the pituitary gland starts to secrete prolactin. You can get a tumor of the prolactin of the pituitary gland. And that, let me show you. So you have the cells in the pituitary gland that secrete prolactin. If you have a tumor in here, it starts to produce extra and excess prolactin, okay? This high levels of prolactin can cause, it can cause a disruption in your ovulatory pattern. It can cause problems with your ovulatory cycle, okay? So it's the pituitary gland that may have a tumor in it that produces excess prolactin. So when someone's prolactin is very high, you want to get a pituitary MRI. You want to get an MRI that, let me show you, if this pituitary gland starts to get large, it can produce extra prolactin hormone. One of the things that's also bad with it is if this pituitary gland starts to get really big, you see the space between, we call this the infundibulum, the neck of the pituitary. If the pituitary gland gets really, really high, it can press on this part of your brain. Now, I don't know if you can see it, but there's a slight blue line where it says optic chiasm. That's where the optic nerves run. And if this pituitary gland starts to get really big, it can press on the optic nerves as they cross over. So the first thing that they lose is peripheral vision. So if she hasn't already, well, I don't know what her levels are. She probably needs to get a pituitary MRI, and if it's large, she needs peripheral visual fields. So yeah, she probably needs that investigated. But if it's
presently the level is 69.
Okay, so it's not too bad. Did she get an MRI?
Okay.
Did she get an MRI done?
I don't really know. Actually, I was not informed, these are children trying to actually elevate issue of fear in me. So I was not informed on time. So it was when the third miscarriage happened that was now like, wow, what's happening? So it was then the whole thing was actually made known to me. And
so Dostinex reduces secretion of prolactin. So as long as the prolactin level is not very high, if you give Dostinex, cabergoline, it reduces the level of prolactin, and it can also cause a reduction in the size of any of the pituitary tumor that you may have. So most of the time, if people stay on cabergoline or Dostinex, you can actually suppress it so it doesn't continue to grow.
Okay. Thank you very much.
Thank you. Thank you so much. So in follow-up to that, when the pituitary secretion is curtailed, what are the chances of sustaining the next pregnancy?
Well, so I'm not so sure that that's the only reason why she had a miscarriage. I think she needs to have a complete workup to see what else is going on. You need to have the uterus looked at to make sure you don't have any abnormality in the uterus. You also want to check your thyroid hormone. You probably want to also check your peripheral. You want to do a peripheral chromosome analysis to make sure you don't have any genetic abnormalities of both the wife and the partner, in case you have what is called the translocation that's causing it. It's unusual. It's rare, but it can happen. Now, having said this, most patients who have had even up to 3 miscarriages will still go ahead and have a normal pregnancy. So just because you've had 3 miscarriages doesn't mean that you're going to keep getting miscarriages.
Yeah.
Most people will go ahead and have a normal pregnancy.
Yeah. Can I come in a little?
Yes.
Yeah.
Yeah. All the tests were actually carried out on both of them. Everything, thyroid, everything. Even recently, they went for the estrogen test, and it was around 250 or thereabout. So everything is actually except the issue of the prolactin.
Mm.
At least from what I heard, or I was, and she sent all the test list. I can forward the results to Toyin. Maybe she can share with you. I have the results of all the
So,
things.
yeah, so I mean, if you can, most prolactinomas are very, very responsive to Dostinex. So, and it really is able to curtail the level in a very effective manner. So most people will respond. And most people, if they have a microadenoma of the pituitary gland and they're able to keep their prolactin levels suppressed, it also prevents the tumor from getting bigger or getting worse.
Okay.
It's only when it exceeds 1 centimeter that they consider that a macroadenoma and it needs neurosurgery to remove it.
So it's a good thing that the right drug was instituted, and that was started today. So kindly
Yes.
keep us updated so we
I'll surely
know
do.
how it goes. Thank you.
Yeah.
Okay. Thank you, Doc. Thank you, Dr. Tony. Thank you, Doc.
Yeah.
Thank you. So kindly pull the slides down so it makes it easier for me to
Sorry.
navigate the audience. Thank you. So Auntie Tawa, you have your hand raised.
Yes, please. Good evening, Dr. Famuyiwa.
Yes.
Good evening.
Exactly. Good evening, Dr. O. Good evening, everyone.
Good evening.
My question is, I know a lady, she's been trying IF so many times. Is there a cutoff age? Because it's so funny. She decided this is the last one she wanted to do. Many people advise her not because she's 58, but she did it and it's thick. So
she's 58.
58, and the
And
pregnancy
she
is
had
like
donor
5 months.
eggs, right?
Excuse me?
She had donor eggs given.
I don't know what.
She must have. It wasn't hers. I can tell you that. It wasn't hers. She must have used donor eggs.
Unless she froze her own.
If she froze it, you know, like 15, 20
saying.
years ago,
Mm-hmm.
Where is she?
Here in US.
Yeah. So yeah, most people would not transfer an embryo into a 50-year-old anymore.
Exactly.
So that's considered almost malpractice. And the age that you cannot get a transfer in America, you're looking at 52. So she needs to consider getting a surrogate.
Actually, she's 5 months pregnant, is what she said, right?
She's 5 months. Yeah.
Yes.
So
I think that's what I heard.
Understand.
Yes.
Yeah. Pregnancy causes a lot of stress on the body, right? It's tough to go through a pregnancy at that age. So some patients, the reason they started reducing the age is people could have a cardiac event. They could have a stroke, any number of complications from being pregnant. So most high-risk pregnancy doctors, at least in the US, probably don't want to come near you with a 10-foot pole. It's been done in the past. I mean, you've heard of grandmothers helping their children carry babies. I think now it's just has been declining, albeit the incidence of complications is not very high, but it's not funny if you're the 1% or whatever percentage that has that complication. They can be serious, serious complications. So it's not something to take lightly.
Thank you.
But she's doing well at 5 months. 5 months
Yes,
pregnant.
she's doing real good. She's a nurse, so she's doing well.
You know, my take, glory be to God.
Amen.
I love this. It's going to be a great story. By God's grace, she's going to have the baby. Mother and baby are going to do well. We do see aberrations, don't we, Dr. Famuyiwa? We do see aberrations in medicine because at the end of the day, there's only one final answer, and that's the Lord.
Amen.
Yes. So, but actually, Dr. Famuyiwa, I think, I don't know if it's still the standard, but if one clocks, I think it's 45, they will not do IVF and use that person's eggs anymore, correct?
Yeah.
Is it 45?
Well, see, because the success rate is so low, it's almost so unfair to raise someone's hope. Although having said that, my oldest patient using her own egg was 45.
Wow.
Yeah, but that's not the general rule. Most of them do not get pregnant. So I don't want to give anybody false hopes. So what I always explain to patients is most fertility treatment is expensive. It's expensive, right? So look at this analogy. If you have one pile of money and you put that pile together and you say, okay, how am I going to spend this little pile of money to get a child? And I tell you, you could spend this pile this way and get a 60, 70%, maybe even 95% chance of walking away with the baby if you have genetically normal embryos. Or you take the same pile of money and I tell you, you have about maybe 1 or 2% chance. What do you want to do? Now, if you have two piles of money, you could say, okay, fine. I, like to gamble. I have two piles of money. So I want to spend this pile of money first on this. And if it doesn't work, then I'll spend the second pile of money going there. I've actually had an instance where I actually had to beg a patient. I begged her husband. I'm like, no, don't stop. No, this is ridiculous. Your chance is not very good and you're going into debt. It doesn't make sense, And he goes, well, I just want to make my wife happy. I'm like, I get it. Of course you do. I understand. But if you do, this is the avenue that will give you that higher success. And instead, trying to get a second mortgage or going to, get a loan and going further and further into debt with a low chance of success may not be the financial best thing to do.
That makes sense. Whew. So there's a question in the chat box, and it says, is there a nutritional profile that is preferred that supports a successful fertilization?
So if you recall, a few minutes earlier, I told you, and I actually do have, I think it's on my website, it's on my YouTube site for sure, and I know it's on my LinkedIn site, but there's a brochure that I created for our patients called the Fertility Action Plan that includes some dietary advice based on research that I did, and when patients always ask me what kinds of food. So if you want, I can put the link to Dr. O, and she can share with you. We actually even made it into a little slideshow. I'm not sure if I didn't put it on TikTok, but it's on all my other social media sites if you want to cruise through, but I know for sure it's on my LinkedIn site. And I made it into a video that you can take your time to look at. So if that answers your question, I'll try and find the link and I'll put it in there on the chat.
Please.
Yeah.
Dr. Craig, does that answer your question? I'm asking you to unmute.
Yes, it does, pretty much. And it's not so much the foods that are being consumed. I'm speaking in terms of the actual levels of, say, magnesium or vitamin D or things of that order. So many of us are actually, hypo and hypo levels with some of our nutrients, and I'm just speaking at that level. Yes, eat the right foods, do the right thing, and you're okay. But sometimes it has to go even deeper than that.
I'm going to put that link in the chat for everybody.
Please.
And you can,
Thank you.
that's it right there. So you're probably talking about macronutrients.
Yes.
I don't like to break down too much because when you start getting too complicated, you confuse people. I believe in eating an overall healthy diet with a lot of fresh, healthy vegetables and fruits. And then I think we're on this same forum, we've had numerous conversations about where do you get your vegetables and your fruits, right? But one of the things I like to tell my patients, I know I love Sanjay Gupta. He gives a lot of useful advice. But one of the things he talks about from his background, he said, if you don't know, there are two techniques I tell my patients. Number one is Sanjay Gupta's technique, which is if you're getting vegetables on your plate, mix the colors. There's something that the yellow things they're doing and the red ones and the purple ones, your cabbages and your bell peppers and, have different colors will provide different nutrients, right? And I know there was another plate technique that I also read where you can do your plate, make sure half your plate is all vegetables, half is, one of your slow carbs, not unhealthy carbs, and the other half is healthy proteins like healthy fish. But for vegetables, I love vegetables. Mix up the colors if you don't want to worry about the macronutrients. Now, in that YouTube link that I gave you, I did go into a little bit of what each thing has. You might have to slow it down, pause it, look at the individual slides, but I did put it in there for the purists who want to go further. But for most people, if you're able to do just that, is mix up the colors, make sure you're eating healthy cruciferous vegetables, and nuts that have a high antioxidants, your berries, very rich in antioxidants, kiwi, high content of vitamin C, watermelon also keeps you hydrated and high vitamin C. So there's a lot you can do. I'll give you a little anecdote. When I grew up back at home, so I digress. This was back when Lagos still had a lot of trees where I grew up. And it was, I don't know if you guys know about the old breadfruits, this huge, in our yard, we were surrounded by trees. You would have to go miles to see the next house. And in our yard, we had, pawpaw, we had pineapple, we had what we call fruit. I've never seen it here. You know the one I'm talking about? I don't know the English name. We had the real cashew fruit. We had oranges. We had guavas. We had some fruits that I don't even know the English name. Agbalumo, I don't know if anyone knows the English name. Yeah. So, and then we had, a well and a water spigot in the yard. And we would play outside all day. And sometimes even for, during summer, forget to come inside to eat a real meal because we were busy eating everything in the yard that fell off the trees. So I love fruits. I love vegetables. And one of the easiest way to eat it, and I tell my patients, make a habit of having a fruit bowl on your table. That's little decorative centerpiece. Well, put different fruits on there because if you have fruits, you will eat them. But if you have snacks that are not necessarily healthy, that's what you eat when you're hungry. So I love kiwis. I love so I keep a fruit bowl there. And all the things that I put in the fertility diet, by the way, here's another favorite saying from Dr. Sanjay Gupta, keep sharp. All those things help you live a healthy life anyway. And guess what? It decreases the incidence of dementia. Who doesn't want to grow old with all their, faculties working well? What we call fruit. Oh,
what we call fruit is almonds.
No, not almond.
No,
there's one that
we're talking about agbalumo.
Not agbalumo is. I don't know what that one is. But
agbalumo is cherry.
There's one that's sort of pinkish white on the outside, and it looks like a pear-shaped, but when you bite into it, it's a white, and it's very juicy.
It is almond. It is
African
almond.
star apple.
No, that's not almond. You call it apple.
It is almond. It is almond. I grew up with it.
No. That's fruit. Almond is fruit.
It is almond.
It is so good. We don't know what.
I love this. I love this.
I love it. It's almond.
It's white and pinkish on the outside, and when you bite it, it's
almond.
white, and it just drips juice.
Yes, it's almond.
It's out. Okay.
Then you crack the inside.
No.
Not that
It's
one.
apple. It's called African star apple.
Yeah,
It's the African apple.
It's
the
African star apple.
Yes,
Mr. Duarte.
We've been away too long ago.
It's the African apple. It's not similar to the American apple or the Western apple, but it's the African apple. It is so good. So
Mr. Duarte. Mr. Duarte, sir.
Yeah, it's called African star apple. As kids, we used to play with the session. That is the after you eat the flesh, there is a seed in there that kids used to play with. It's called African star apple. That's what agbalumo is called.
Yes.
Thank you.
So,
by the way, since I have this expert here, does anyone know what agbalumo is in English?
That's cherry. We call it cherry.
No.
Actually, I think a lot of people call it cherry, even though it's not cherry.
It's not.
But people will call it African cherry. But really, it's a challenge, really saying what the real name is.
Yeah, because it's not in the Western world. And when you crack and chew a lot of it, and you chew and fill your mouth up with it, then you can turn it into a little chewing gum. Well, we had the trees in our backyard, so we would cram our mouths with this thing. And then I ate so much guavas that they thought it caused appendicitis in me. But we had the guava trees would literally be dripping of the fruits, and we would let the kids in the neighborhood come in to pick it. Otherwise they would rot. But anyway.
Okay, I have something. Dr. Hannah Ajay just texted this to me. She Googled it. Sweet agbalumo is called udara in an African country, and it's also called African star apple. That's sweet agbalumo that you're talking about. So the fruit that was being alluded to, that it's that Miss Becker was saying is almonds, is true. That is fruit. That fruit, it's inside it, after you eat the flesh and the outside of it, inside is the apple seed. That is not the agbalumo, but it seems like agbalumo is the African star apple. And Auntie Susan Oshifade said it is called Yaba apples also.
So they're not talking about the same thing we're talking about, though. Because I know agbalumo, it's not white. The white one, I don't know.
But they didn't say white. Agbalumo seems to be the African star apple from Google. Now, Google may be wrong.
No. I'm not saying it is, but the one I have in mind, I simply don't know the name for it.
It's orange.
The one.
Color.
No.
The one you call
Brownish.
Odala.
Dr. Izugu, go ahead,
Yeah,
sir.
the one you call Odala, which, when you chew it, it can become a gum. It has little seeds inside it. That's Odala. In Igbo language, we call it Odala.
That's agbalumo.
Agbalumo.
That's
Okay.
the one we chew, and it becomes like
Right.
chewing gum.
Right.
That's
But
agbalumo.
that, and I'm gonna have to call all my siblings. We have to find the name of this other white fruit, because it only grows in to my knowledge, in West Africa. But it's so delicious. Anyway, so now we're all homesick.
So
That's right.
this is fantastic. So all of these fruits you're saying are actually good for fertility, for health. They're good for health too.
Right.
So they're good for the fertility health too, correct?
Yes, because fruits have antioxidants. They're rich in antioxidants. They're rich in vitamin C. They're rich in minerals. They're really rich in so many things and then you combine it with the healthy vegetables. As an aside, I'm going to take you guys to another home vegetables. Ewedu, right? Jute leaves.
Yes.
Do you know? Because I actually did a little research on this. The jute leaf in ancient Egypt was reserved for the royal family, the pharaohs.
Egyptian
common people couldn't eat it. And the jute leaf has some cardioprotective qualities.
It means it protects your heart.
Yes. So go right ahead, load up on that ewedu, eat some nice fish. It's good for you. And also very good, good source of minerals as well.
And on the side, Sister Becca said, right now, agbalumo is in season and sells for $5 a piece. That's expensive.
That's very expensive.
Yes, I have somebody who sells it right now.
It's too expensive.
They need to come to my home and my parents' home in Nigeria and pick their own.
I know. So
I'm telling you.
Mr. Duarte says the white fruit is apple.
We call it apple, right? We call it African apple, but.
And per Google, agbalumo, English name is African star apple. Sister Wumi Kamsin confirms that. Scientific name for agbalumo is Chrysophyllum africanum or Chrysophyllum albidum. That's the scientific name. So agbalumo, we've established, is the African star apple.
Awesome.
Thank you so much.
So if anything, today we're all going to know what agbalumo is.
Yes.
So
yes, but coming back, I have something. I have to. Yeah. I have to ask this question. I have to, make this point. Again, when it comes to fertility, we tend to focus on the woman. We talk about the biological clock ticking. And when we do that, when we say that, we're referring to women, correct? But you have told us, this is the second time you've alluded to the fact that men's biological clocks also tick. I think you mentioned to us at one of your monthly talks that when the sperm is old, it has the tendency to produce children with autism. Am I right?
Yes. Okay. There have been a link to autism, and also you also have an incidence of aneuploidy. I'm going to keep saying the word till everybody becomes familiar with it. Aneuploidy. That is when, that's right. When you have a genetic accident in an embryo that's not necessarily inherited, is when the sperm and the egg fertilize and you don't get a proper alignment, or there's missing chromosome or an extra chromosome. Most of those are not compatible with life. They're not even compatible with fetal life. And when you do get pregnant with them, you can get birth defects. The only aneuploidy that is compatible with life is Down syndrome. So with Down syndrome, you can go ahead, and we know that Down syndrome babies can do well and grow into functioning adults, and that's not a problem. But there are some defects that are not compatible with fetal life, not compatible with life. And it's tragic to go through a pregnancy and have an aneuploidy and have a miscarriage at 7 weeks, 8 weeks, 10 weeks, and have it keep repeating. And there is a way to test for aneuploidy now if you were to go through IVF. Some people say, well, you don't really need it if you're young, only test older women because the incidence of aneuploidy increases with age. And then there's another argument that, well, maybe younger women want to know too, right? Because a statistics is only a number until you're that statistic, until you're the person going through that aneuploidy and having that miscarriage. It's devastating. The pain of a fetal loss, it's you don't really get over it, right? People say, oh yeah, get over it, you'll have another child. It doesn't quite work that way. You have to mourn that child. You have to, because every year you have an anniversary, you'll always think, oh wow, my daughter could have been this age now, or gee, I wonder my son could have been this. So there is an ongoing pain, and you have to mourn that loss. And one of the things I tell my patients, if you will, is that, well, at least your child is in a better place and they don't have to earn their ticket to heaven. And hopefully they got a straight ticket to heaven. We, the rest of us, we have to earn our way to it. But it is a loss. And the inability to have a child is also an equally serious loss, right? It's a loss when somebody is saying you can't have a child. It's devastating. And people need to mourn that. You need to give yourself the emotional space to mourn. You're not a superhuman being. It's not something you ate, not what you did, not where you went to. It is not of your own doing, right? So you need to give yourself permission to mourn, to heal, to recover before you go forward.
Thank you. How about the men? That's the women. The men.
So I'm telling you now. I'm telling most of my gentlemen, if you are over 50, circumstances happen. Maybe you're not married for whatever reason, but you still nourish the thought, and you're maybe 60. It's never too late, right? And if you still haven't found Miss Right, well, guess what? Freeze your sperm.
So, thank you. We know about egg freezing, but nobody talks about sperm freezing.
Yeah, freezing.
I think we need to start balancing things in our communities. And this is why I keep pushing that you address the issues of men too. When it comes to fertility, this is an important aspect, or another example of where things are not balanced. Focus is put on the woman. What about the man?
Yeah.
The men are equally important. Men, even in our culture, when a man is not getting married on time, you hear people say, oh, it's a man. It doesn't matter.
It does. It does.
They can take their time. Yeah. Men don't have to rush. It does. It does matter. Let's make hay when the
sun shines. Yes.
And so if a man is not ready to marry on time, now we know they need to freeze their sperms too, just like women need to freeze their eggs.
Yeah. Yeah.
So I have some questions here that says, is it possible to ovulate twice during a period instead of once?
Unlikely, because unless you have a very, very short follicular phase. Remember I showed you that follicular phase and the luteal phase? unless you have an extremely short follicular phase, you can whip out an egg that fast. In general, probably not.
Well, you know what I've seen in practice, when people think that they are ovulating twice, they having menstrual period twice in a month, is just because they probably don't know their cycle. Like you mentioned before, you have to know the first day you started menstruating, and you count that to the next time, the first day that you start again the next time. So start to start. So if you have a 28-day cycle and you menstruate on the 1st of March, you're going to menstruate again on the 28th of March. I've seen patients come to me and say, I menstruated twice this month. Something's wrong with me. And when I say, okay, keep a calendar, let's make a note of this. Keep a calendar, come back in 3 months. And I say, oh, you have a 28-day cycle. Guess what? The reason you did that twice in March is this. Is oh. So we need to know that cycle to be able to, make an educative decision. Another question, I'm going to run through them quick because of time, says, are there ischemic issues that occur to sperm cells that are frozen? Sperm cells that are frozen, could they have ischemic issues from the freezing?
No, I mean, if your sperm or egg it's frozen, then the age is paused, right? You put a pause on things. So it should not, freezing the sperm should not necessarily, you do have sometimes a decrease in sperm morphology and motility when you freeze the sperm. So when you try to thaw it and revive it, you may have a slight decrease in its functioning, but it can still fertilize an egg.
Thank you. So this is a very important question. What are the tips for mitigating risk in women 50 years and older carrying a pregnancy by IVF?
So first off, you want to make sure somebody is in very good health, right? You want to make sure, that you don't have diabetes or high blood pressure or high cholesterol, renal disease or liver disease or any systemic illness that's going to make it hard for you to carry a pregnancy. Second of all, you want to evaluate the uterus, right? So some people have fibroids or adenomyosis, and it's difficult for them to implant. So as long as the uterus is normal and they're in good health, they can successfully carry a pregnancy at age 50.
Thank you. So Dr. Cindy Success Abidjar, thank you so much for that link to the African star fruit. I'm coming back to fruits. We're not going to leave this issue of fruits alone, okay? Because somebody said, what about dwarf's apple? I don't know what that is.
I don't know what that is.
Dwarf's apple. Jay, do you want to come? Do you want to tell us what that is to everyone? I don't know what it is.
Are you saying dwarf apples?
Yes.
Dwarf apples are crab apples.
I don't know what that is.
They're small. They tend to be very, the meat tends to be very firm. Sometimes they're not very sweet. And they have really a short life in terms of a fruit existence.
Wow. Well, I know that because they are fruits, they will be antioxidants, most likely, correct?
True.
Okay, cool. I'm gonna Google that to see if I can, find that. I like to try it. So this brings us to the Medical Mondays moment. Can you believe that half of March is gone already? And to the glory of God, things are getting better. Yeah. Things are shaping up. I went to Giant the other day, and at least 50% of those in the store had no mask on. Another 50 had mask on. I had my mask on.
Wow.
And I went to one of the employees there who didn't have mask on to go ask what was going on. Because I've walked into Giant before in the heart of COVID and forgot to bring my mask with me. And somebody quickly stopped me. I had to run back to my car. So he told me, oh, now it's your choice. You can wear a mask if you want or not wear it. So I look at it in a positive way that at least we're easing into some normalcy. However, I have made a decision that in our settings, we're still going to be wearing masks until we know better. And so I wish us all the best, and I just want to encourage us to still maintain safe practices, get vaccinated, and let's keep healthy. Let's keep healthy. But I think it's a positive that we're moving in that direction, in the right direction, to mask off. We miss Honorable Gustav, but I'm going to give it back to you, Dr. Famuyiwa, to give us your concluding advice, your concluding statement.
So you're talking about a field that I really, really like, and it's near and dear to me. But when somebody has difficulty getting pregnant and they're younger than 35, if you've been trying for a year, please seek out help. And if you're over 35 and you've tried for 6 months, please seek out help. There are some basic things that we can start working on to start getting some basic answers. And the sooner you seek out help, the sooner you get the correct treatment that you need, and hopefully get you closer to your dream of building or adding to your family.
Thank you so much. And I wanted to say that we have been blessed. We have learned a lot. However, we have not established care on this platform.
Right.
This platform is for informational purposes only. It's not to establish care. And next week, guess what? We're going to have an ex-NFL player, a Super Bowl champion, a Super Bowl Ravens winner, coming to tell us, to educate us on how to get healthier. At his age, you need to see him. So totally amazing. I am so excited that next week we would have another treat. Every week is a treat.
Excellent.
Haven't you enjoyed Dr. Famuyiwa? I mean, aren't you proud that this is one of ours? And we coming next week, the speaker coming next week that I'm talking about is Obafemi. His name is Obafemi. Stay tuned. He's a Nigerian Ravens champion. I'm a Ravens fan. Hoo-hoo! So for me, it's layers of excitement because I'm go Ravens, go Ravens, go Ravens all the time. You don't want to see me on the field. You don't want to see me when it comes to Ravens season. So until next week, I pray that the Lord keeps us safe and keep healthy. And we'll see you then. Thank you so much for another amazing Medical Mondays with Dr. O. God bless you all. Thank you.
Dr. Famuyiwa.
Thank you, Dr. O. Thank you, Dr. Famuyiwa.